funny. Okay, hold it up right here. Once the initial swelling has gone away, and of course all the local scarring there. Don't let me push this down. Okay. The various heads of this. Okay, same thing over here.
Ha Right away.
There we go. Hold it right there.
Yeah.
Tell me if you start to cramp here.
Wow.
I think I know where we're going to go.
Yeah, definitely.
Yeah.
That's pretty impressive. So I can imagine what the MRI is like.
Yeah, and he said 10 centimeters of retraction.
Mm-hmm.
That's probably almost a palpable 10 centimeters. So that's what we're going to fill this booger up.
So
here.
you fill the entire space is what you're attempting to do.
will. And we're going to actually have probably 24 cc's of stuff.
Exactly.
So we're going to, I'm going to make sure that I go right around the two ends.
Okay.
Wow, let's see. So we'll make sure we stay superficial and not stay out of his nerve. And so I'm going to make sure I saturate the two ends, and then I'm going to fill the defect in the middle, hoping to get the myofibroblastic connection there. But wow, that's a defect.
Yeah.
Wow. Well, I mean, really, I can't. It feels like it comes into right here.
You did good, kid, right?
Yeah, I can feel kind of some bald,
Yeah.
some
I would
tissue with
say
some
there.
integrity over there. If you look at this other side, bend this one up. I mean, he's rock solid all the way down.
Oh yeah.
So
That's very impressive. Yeah, you're right.
we do them in the back too.
Mm-hmm.
But patients tend to tolerate a lot more if they're straight up looking at you.
Sure.
They're seeing when you're struggling, they're seeing when you can put some effort, and they kind of brace themselves for that.
Mm-hmm.
When they're awake in our local anesthesia, you're doing it from the back, they get a lot of anxiety about that.
Okay.
It's a little easier to get from the back, from your point of view.
Sure.
I think it's tougher on the patient.
Yeah, it's all about the patient.
Yeah, it really is. And if I'm doing them under anesthesia,
Right.
I'd do them prone. If I'm doing them awake,
Right.
supine.
Okay.
So we're going to go back about 3 finger breadths.
Below ASIS?
That's it, just right along the ridge here. And this is where we're going to work. It's right there. And if you feel it, you can actually, of course, he's so musculature. Or you bet you're ticklish, aren't you?
No, it's just, it's,
Uncomfortable or
yeah,
scary?
I don't know.
Okay.
I'll let you know afterwards.
He's so muscular, every time he breathes, it's kind of pushing my fingers that way. We'll work around that. But you can see how thick his iliac crest is right there.
Okay.
Now, all those years of his abductors and his rectus, particularly obliques, pulling that thing, that bone's going to be concrete. We're going to have a hard time getting through that. That's okay. It's going to be better than the back of the bone would be.
Okay.
Now, the way that the pelvic, the conical shape of the pelvis runs in here, if you enter this, now I'm going to anesthetize and pull his musculature up out of the way.
Okay.
The nice thing about that is when we go in, take the aspirate out, which is really just a puncture hole in the bone. His muscle is going to fall back down over it and seal the hole so he won't have the big ecchymotic area. This little crazy thing we're using here is 34. Okay, we use jokishly small compared to what I used to use. Patients tolerate that.
Very good. Because that's what everybody's concerned about.
Okay. So just by entering the hole there, we're already tamping out the bleeding. It's that small a hole. Okay. So same thing. We're going to go, I'm feeling the outside of the table. We go right on top of the crest. You didn't feel that, did you?
Okay.
Okay, so I'm going to pierce perpendicular to the crest. You're going to feel pressure.
Yeah.
This really shouldn't hurt you much. And right, but I can feel the inner and outer table. I'm just going to pierce that. Okay, as soon as I pierce the outside so I don't skive off, I shoot towards contralateral popliteal fossa. We're going to go right in the bone. How old are you? I forgot.
27.
27?
Sir.
Okay. Do you know where bone peaks its density? 27.
Is it really?
Yeah. It stays there until about they're 37.
Oh, no, she has one open.
So just hit.
I just need a couple of these.
Pierce the outer table. We're already in. Not killing you? I'm not killing you?
Okay, okay.
Yeah, I mean, it's not a lot of minutes.
I only need a little bit. Wipe it?
No, I didn't, not yet.
Alright.
And it's flowing right in there.
Okay.
Now, it's likely to hit a spot deep enough that you have legitimate pain, not just that pressure and discomfort. When you start to legitimately feel that, you tell me, I'll stop.
Okay.
And we're deep enough now, kind of.
Keep going.
But the deeper we are, the better we
All
are.
right.
So you just kind of keep me posted.
So-
Putting about 20 pounds of force. Maybe see me, I'm just, I continue to check my alignment. Hand cramp when you know it.
Doing good, Greg? Awesome. Almost there, so gonna have to draw it.
Looks like it should be more difficult, doesn't it?
It does. You know, I thought it would be truthful.
That grafting is going to be bigger and better than this.
Okay.
Ah,
There it is.
3 centimeters. Hey, we're in great shape.
okay, we keep
Yeah.
going.
Dude, no, you're great.
Little pressure here,
Very cooperative. Yeah, you're going to feel this for just a moment, okay?
just for a second.
As it disengages the needle.
Ah,
See?
Yeah.
It's already gone, isn't it? Okay, you ready? Oh, dude, he said a bad word.
Yeah, but it's okay. Remember, anyone who has a BMA needle, can say that.
Oh, I forgot. I forgot that that's a.
We can't say it, but he can.
You're going to feel it's not going to get any worse than this right here, okay?
Can you handle that?
yeah, it's pulling out of my knee.
Right.
You know, it does. They always feel like it's
Yeah.
coming out of their femur.
Really?
I do not understand that. They
can't.
always say it feels like it's coming out of their femur, out of their thigh down toward the knee.
Get
Just
that
on
whole
the nervous
shot.
innervation?
This whole hand.
I can't explain it.
Yeah.
And that.
Because even if you bag one of the cluneal nerves going across the top there, they'd feel that in their buttock, wouldn't
Right,
they?
yeah.
Oh, you know what I did?
Probably need to be here to get the dressings.
Okay, I got about 62.
I'm good. I'll take that.
Excellent.
So we're giving us a little extra counterbalance.
Where's that? Good.
Got about 65 out of him.
Okay. Good.
More than we'll ever need. All right, Nanner.
Yes, sir.
Come right here first. You can see what she's going to do next. So what Anna's doing is she's priming now the platelet-rich plasma. This is the plasma on top. This is the buffy coat. This is the red blood cell layer. She's taking some of the plasma off to prime it before we put it into the pilot system. Now the pilot system has a little red laser in here that measures cell density. And what that does is, as the cells go through there, it lets us know exactly where Greg's largest, most healthiest platelets are. And then it stops the system. Good. And she's going to hit start. Okay, good. So what this system is doing now is it's pulling the plasma off. And pretty soon, when it gets down to this red layer, you're going to see a little bit of white come out. That's the buffy coat. And the buffy coat comprises of the white blood cells and the platelets. And that's what we're trying to concentrate, the white blood cells and the platelets and some of the plasma. Now the largest, strongest, most viable platelets are right below the red blood cell layer, deeper down, because they're larger and they're younger platelets and they're healthier. So we go down about 3 cc's below the buffy coat into the red blood cell layer to get all the platelets that are in that area. They separate by density, so the youngest platelets, which are the largest ones, are the healthiest ones, actually go deeper.
And they shrink with age?
That's right. They shrink with age. So right now, if you get real close, Lloyd, you can see that little red coming out, this white stuff, all that white stuff. See that white stuff? That's what we're after. Good. So it stops. You see it hit this laser and it stops. We know that everything in here, if you see this is all kind of white and chunky.
Right.
This is all from here all the way to here is all platelets. So go ahead. I want you to draw back. Anne's going to shut the valve off to this syringe because all she wants now is 6 cc's of this. So take 6 cc's of that,
Of the richest part.
of the richest part.
Huh.
That's it. Mm-hmm. Good. All right, she's done. So you can counter.
Oops.
Marking this spot. Putting some gel on you, Greg.
They thought I had Mexican or something like that.
Sounds like it might need some work. Or would you put me to shame or something?
The other PRP?
Yes, sir. Hmm.
Okay. So you can see his defect. So we're going to, and it kind of stops there, it kind of stops there. So we're just going to get that defect right in the middle. And this is where the peppering technique comes. And this is when he decides he's never going to speak to me ever again. Sorry, man, it's going to hurt. So we know that there's a defect right there. So make sure I saturate everywhere that I can palpate.
Okay.
Because even though we saturated the area under ultrasound.
So you're using a significant amount of PRP.
Oh, you slow down.
12 cc.
Sure. I'm almost done though. You want me to finish?
Alright, just go.
It's like not even a CC, right?
Yeah, and here comes the part he's really gonna hate. Dry 4x4.
Yes, sir. Here you go.
Gotta move it.
Make sure it saturates through all the tissues there. Okay, pull all the way up, bend all the way up. Okay, straighten it all the way back out. Ooh, you got spasm there all of a sudden, didn't you? So I'll pull it out. I'll soften it back up for him. I would suggest you drop by that pharmacy and get that prescription. And then, you didn't have to bring an ice bag, did you?
No, I did not.
Stop by 7-Eleven, get some ice.
Yeah.